Hi.
It works.
Oh, yes. Thank you so much.
No worries, no worries.
I appreciate your patience. Let me see.
Hopefully they'll
Uh,
come back.
yes, yes, yes. Hopefully. Let me,
Hair's a mess. I got beach hair. Sorry.
oh, no, no, no. You look fabulous. You look fabulous.
A mess.
Um, let me see. So let me go share this link to invite others to join.
So it just FYI, it's telling me that I don't have access to comments or reactions. So you'll have to, if more comments
Oh,
or questions come in, you'll have to, tell me what those are.
okay. Okay. Will do. Definitely. Okay. Okay, great. Thank you. We have some people who are coming back into the room.
Good.
Excellent. Excellent. Okay. Thanks so much, everyone. I see Monique is here and Michelle is here. Thank you so much. And let me see. Monique and Michelle, are you able to hear us okay so far? Awesome. Thank you guys so much. I appreciate that y'all were able to come back in. Okay. Excellent. Excellent. Okay. Well, thanks so much. Thank you guys for joining. Thank you, Dr. Wilson, for being here.
Thank you for inviting me. I am so glad to be here.
Oh, I'm so excited to have you. And thank you for coming back in, and thank all of you for being troopers. Sorry about the technical difficulties. So we are going to go ahead and get started. And this is a live that I've been wanting to have for a while. Dr. Tracey and I work in fields of medicine where we sometimes have overlap because we both take care of women. But Dr. Wilson does very unique things. And so I wanted to make sure I could bring her on and highlight her, especially also because this is the end of Women's History Month. And she has this very rare position as a woman who does urology, but also a Black woman who does urology. So thank you for being here. So let's go ahead and get started. And again, as you guys come into the room, as we're talking, if you have other questions that you have, please, by all means, just let us know. So to get us started, I'm Dr. Madeline, your board certified OBGYN, international speaker, published author. I love working with busy women, whether they're busy inside of the home or outside of the home, to help make sure they have accurate GYN information and birth control so that they can have the most freedom and control over their lives as they desire. So today I'm very excited to be here. We are on the last Sunday of Women's History Month. We made it, y'all. We made it through March 2021. And it's certainly been a long month, a long year, but we're all trucking on. So I want to, without further ado, introduce to you the amazing Dr. Tracey Small Wilson. So please be patient with me because she's done a lot, and I want to make sure to highlight her because she's very special, and I'm glad that you're here, Dr. Wilson. So Dr. Tracey Small Wilson is an associate professor in the Department of Urology at the University of Alabama at Birmingham. She completed her undergraduate studies at Georgetown University. That's where we met, y'all. We're Hoyas. And a medical degree at Howard University College of Medicine. She received her urology training from the University of Connecticut and fellowship training in female urology, neurourology, and urodynamics from the University of Texas Southwestern Medical Center. She is board certified and was the first, okay, I think y'all need to understand me, the first, and we're talking about in the 2000s, the first urologist in the state of Alabama to receive sub-certification in female pelvic medicine and reconstructive surgery in 2013. Dr. Wilson is now a member of the American Board of Urology Examination Committee. Well done, Tracey. Dr. Wilson is currently the Urology Department's Director of Medical Student Education, and she also directs the reproductive module for all second-year medical students. She is also co-director of the Fellowship in Female Pelvic Medicine and Reconstructive Surgery. Her clinical focus is on the diagnosis and treatment of pelvic floor disorders in women, as well as the urologic care of male and female patients with neurogenic bladder dysfunction. She has a particular interest in the spina bifida population and leads a multidisciplinary team in the care of that population. So y'all understand why I wanted to close out Women's History Month with Dr. Wilson, right? She is amazing. Thank you so much, Tracey, for all you've done, all you continue to do, and I'm honored that you were able to join us today.
Thank you. Welcome. So glad to speak to you and to your audience, and enlighten them about bladder health and answer any questions that they may have.
Okay, awesome.
So I can start a little bit. As Dr. Sutton mentioned, I am a urologist, and most people acquaint urologists with males. However, we do see a number of women, whether it's related to disorders. Basically, a urologist, first of all, is a surgeon who specializes in the urinary system of men and women and the reproductive system of men. And that's why we're usually associated with the male population. But again, we do serve women who have kidney stones, kidney cancer, bladder cancer. And then where my subspecialty comes into play is with bladder health or urinary tract infections, urinary incontinence, and pelvic organ prolapse, where your organs prolapse or herniate through the vagina. And that's something that we can touch on if we have time. But that's pretty much where I spend my time in the pelvis, and primarily operate through the vagina. And also, primarily help women, again, with urinary incontinence. And so my colleagues have many grateful patients who they have helped with life-threatening diagnoses such as cancers. In my field, I deal with patients who have quality of life disorders. So when your bladder is not functioning well, unfortunately, it can truly affect your quality of life. And although I chose not to specialize in diagnoses that were life-threatening, I felt my calling to serve those patients who couldn't enjoy the basic things that we take for granted simply because their bladder was controlling their lives, either through urinary incontinence or pelvic pain or urinary tract infections. And those are some of my most grateful patients. So I thought I would touch base first on urinary incontinence, which is very common and is I think the three most common types of urinary incontinence that the general population would experience, and that being patients who do not have a neurologic condition like multiple sclerosis or some type of spinal cord injury or even diabetes. But for pretty much healthy women, which can span the ages of 18 to 99, the most common types of urinary incontinence are urge incontinence, which is leakage when you can't get to the bathroom quick enough, which is oftentimes preempted with just urgency and frequency. And frequency can mean a lot of different things to different people, but in black and white, the frequency is defined as more than 8 times urinating in a 24-hour period. And nocturia, which means getting up at night to urinate, and specifically that means being awakened by your bladder. Again, we all get up from time to time, and we might get up once. It's diagnostic or pathologic when you get up more than twice. So when somebody has frequency, going to the bathroom more than 8 times in 24 hours, or urgency, feeling like you can't delay it, that oftentimes leads into urge incontinence, where you are leaking when you can't get to the bathroom quick enough. The next most common type let me back up a bit. Urgency, frequency, and or urge incontinence is sometimes bundled together as overactive bladder. And that's something that affects probably 40 million women in this country. So you are not alone if you're experiencing those symptoms. The other big type of incontinence is stress incontinence, which is leakage that occurs with any type of stress maneuver where you have an increase in abdominal pressure. And that increase in abdominal pressure comes from flexing your abdominal muscles. So that can occur with doing a sit-up, which is, probably the one that we can all identify with. But we oftentimes leak with doing things less strenuous than a sit-up. Sometimes it could just be simply picking up a toddler, or picking up a bag of groceries, or a bale of laundry, or even going from the sitting to standing position. Anything that requires that straining type of maneuver and it causes you to leak, that's called stress incontinence. Some patients have a mixture of urge incontinence and stress incontinence, and therefore it's called mixed incontinence. So those are the three most common types for neurologically intact patients: urge incontinence, stress incontinence, and then a combination of the two, mixed incontinence. When should you seek treatment? It really depends upon every individual. It basically depends upon when you are bothered. I have some patients who come to me and are wearing one panty liner a day that has a quarter size amount of soilage on it, and they are overwhelmed. I have other patients who come to me and they're wearing 5 Depends a day, and they say, I'm here because my primary care physician sent me. I'm okay with this. So everyone has their breaking point.
Yeah. Excellent summary, Dr. Wilson. And certainly those are things that even also on my side, on the OBGYN side, we see very commonly. One of the things that also happens and might be a trigger for me to refer someone to you, a urologist, would be other type of common complaints. Like you mentioned, lifting the toddler. There are some women who, when they sneeze or laugh or cough, they might feel a little trickle as well. One of the other things that happens, and you kind of touched on this, quality of life. Sometimes quality of life is, I'm trying to get busy with my partner and, I'm uncomfortable because I noticed that there's some extra leaking around my bladder area. So, so take me through, if I refer a patient to you, sometimes one of the things we start with is something called urodynamic studies, because we're trying to, from the OBGYN part, we're trying to give you a little bit more information before they get to you. So tell us, what are some of the things, and we've had some people ask about this in the past, what are some of the things that someone might expect at that first visit with you in terms of like working up what's going on and discussing next steps? Sure.
Urodynamics is a very detailed assessment of bladder function. I describe it to my patients as like an EKG for the bladder, but that's not something that I would do at a first-time visit, maybe not even after a second or third visit. It's something that if I can't figure it out on my own, getting a very detailed history, then I might go to that type of evaluation. But the first visit is going to be a lot of detailed question about your bladder habits and about your daily habits, because believe it or not, a lot of women can be treated, and it's recommended that we go through these first-line therapies, which are usually just changing your behaviors. Sometimes, I kid you not, we are so busy as women. We're moms, we're wives, we're mothers. We are working, and you get set in your day and you delay urination, and the next thing you know, 8 hours have gone by. And yes, you are leaking on the way to the bathroom, but maybe you wouldn't have leaked if you hadn't waited 8 hours. Some of us go to the bathroom before we leave for work, then you get to work and you don't go to the bathroom again until lunch break, and that's 4 or 5 hours later. So sometimes I will get into very detailed questions about exactly how often are you urinating, as well as what are your dietary habits. I live here in the South. I live in Birmingham. It is not unusual for my patients to come and say they are frustrated about leaking, and only to find out that they're drinking a gallon of sweet tea a day. So, it may not be sweet tea. It could be Starbucks coffee. It could be anything with caffeine. But if you're consuming more than 12 to 16 ounces of caffeine a day, then it's certainly affecting your bladder health. So we truly go through those types of behaviors and see if there's room for improvement. Many times it's a matter of just, trying to remember to go to the bathroom every 3 to 4 hours, trying to limit your caffeine intake, trying to limit your fluids between dinner and bedtime so that you have less episodes of getting up at night. And when it comes to intimacy, yes, Dr. Sutton, it is something that can affect our relationships because, one, we might be afraid of the fear that we smell like urine. We may be afraid of leaking during sexual relations, which is also something that is well known. And again, there's two different types of leakage that could occur during intercourse. One could occur with deep thrusts. It's just like, we just talked about stress or pressure on your bladder, those abdominal muscles with a cough. Same thing could occur with a thrust. We also have patients who will leak with climax. With that sexual stimulation, there's this sort of urethral vesicle reflux that, even with oral sex, there may be some stimulation of the urethra or the clitoris, and that triggers a contraction of the bladder and you lose urine. So those are, it's not something that's wrong. It's something that can occur and should not be frightening.
Absolutely, absolutely. I find that, and you probably find this as well. I think one of the biggest things is getting people to not feel ashamed or embarrassed. You spoke about a very important statistic, and that is that maybe, I think when I last checked, about half of women, it's estimated, might have some type of urinary bladder trouble as they get older. And certainly it's something that's very, very common and probably we don't discuss enough. I like that you spoke about behavioral change and how often it is that will usually lead to resolution. What about medicines, like medications and surgeries? How often do you have to go down that path for someone who may not respond to behavioral intervention?
So I would, I know our primary care physicians are very busy and they're dealing with many different diagnoses, and it's not uncommon for a patient to feel like she doesn't want to add one more thing to the physician's list. The visit is ending and he or she has the hand on the door and, oh, by the way, I'm leaking urine. So sometimes it is not discussed. But if it is, I would hope that the primary care physicians can start with the behavioral changes. And so by the time they reach me, many times women have said, I've cut out caffeine, I've done these things, I've done Kegel exercises. And so now they're heading into my direction, and that's when we would start what we consider second line therapies for urge incontinence, which usually include medications. And when we're talking about overactive bladder symptoms, such as the urgency and the frequency, we're talking about a chronic condition. So just like if you were taking a medication for hypertension or diabetes, if we're going to go down that pathway of medications, then the commitment is long term. I would also just sort of rule out the obvious and just make sure that you don't have a urinary tract infection or any other thing, anything else that's concerning in your urinalysis. So we would get a basic urine study, just you urinating in a cup. And if there was nothing to suggest an infection or nothing to suggest any further evaluation, then we would talk about medications. And so we do have effective medications for urge incontinence and for the urgency and frequency. However, those medicines do have some potential side effects, which many times, is not very attractive to women or wouldn't be attractive to anybody. Those usual side effects are dry mouth. So if your mouth feels dry, you're going to drink more. And if you drink more, you're going to pee more. And you just get into this vicious cycle. So I usually warn my patients of that potential side effect, as well as constipation, which unfortunately many of us have at baseline to begin with. And another side effect can be dry mouth. It's just very drying. The class of medications that we use for urge incontinence are called anticholinergics, which is and they have a profile of side effects that is very common to other medications. There's another class of medications called beta-3 agonists. We have one on the market and one that is soon to be on the market. The side effects of that medication can be a mild elevation of blood pressure, as well as headaches. All of these side effects happen infrequently, but again, when we're talking about a long-term commitment to a medication, then unfortunately, we have a number of patients who drop out of therapy because of the side effects. Now, when it comes to stress incontinence, we do not have any medications for stress incontinence. And so again, your first line treatments would be Kegel exercises, which it is not uncommon for your OBGYN to talk to you about Kegel exercises, especially after childbearing. But
right.
There's not a lot of, I would have to say, just from my clinical experience, I would say 70 to 75% of my patients say they know how to do Kegels and that they've done Kegels and it didn't work, only to find out that they weren't doing Kegels. They're squeezing everything except for those appropriate muscles. And we're talking about your pelvic floor muscles, the muscles you would squeeze if you were trying to prevent yourself from passing gas in public, or if you were intimate with your partner, if you were trying to squeeze your muscles around his penis, or any other type of object. It's those muscles. If you're doing a Kegel exercise and you're sitting comfortably in a seat, like I just now did a Kegel and you didn't know it, but I have many women who are like, they're doing a Kegel and they're bouncing up and down because their butt muscles are squeezing, or their thigh muscles are squeezing, or their abdominal muscles are squeezing. Nothing should move if you are really pulling your pelvic floor. It's like pulling your vagina towards your nose. And so we would start with those exercises, and then we get into surgeries. And the surgeries can be something very mild to bulking agents, where we inject sort of like a filler around the urethra to get it to seal a little tighter. And that's something that can be done in a physician's office or can be done in the operating room. And then we get into slings, and slings can be synthetic slings, primarily polypropylene mesh, or they can be tissue that is donated by a cadaver, or we could utilize tissue from your abdomen or from the side of your thigh. And that's basically where we place a piece of material under the urethra so that when you experience those activities that cause an increase in abdominal pressure, such as coughing or sneezing, the urethra kind of get kinked on the sling and the urine doesn't exit. And then when you're not doing those activities, the urethra is more straight and you're able to urinate without difficulty.
Excellent, excellent, excellent. I think what's most encouraging, which sometimes is not known to a lot of women who are afraid to bring up the topic, what's most encouraging is that there are some solutions, you know, and whether those solutions are behavioral or medicinal or even surgical, women don't have to walk around feeling embarrassed or feeling like they need to go on forever with any symptoms of leakage or anything like that. So thank you for that. That's very encouraging.
Absolutely. If there's one take-home message here, is that urinary incontinence is not a consequence of aging. Just because you're getting older doesn't mean that you have to leak and that you're destined to wear some type of protective padding. If your mother says that that's what happened to her and your grandmother says that's what happened to her, we have had a lot of advancements in this field. And again, it's not something that you should feel like you have to live with. And I do just want to mention, we also have effective surgeries for urge incontinence and the overactive bladder symptoms. If you're someone who's tried medications or interested in medications or have a contraindication or side effects, Botox injections into your bladder are extremely effective. And we also have another surgery which is similar to inserting a pacemaker for the bladder. So when you have overactive bladder, we assume that your bladder has an abnormal beat, just like you may have an abnormal heartbeat. So the same makers who make a cardiac pacemaker to regulate the heartbeat of your heart, that same company has developed what I would consider a pacemaker for the bladder, again, to regulate its beat.
Excellent, excellent. And a lot of times, especially from my end, if I'm seeing a patient who's had these concerns and complaints for a while, I can refer her, and usually the insurance company, because I know sometimes people are concerned about, would this be covered by my insurance company? And most times it is, especially if it's affecting quality of life. So I did want to put that out there as well.
It is. Sometimes they will say, well, has she tried XYZ first before we can get really to the more invasive treatments, but it is usually well covered.
Absolutely. We have a question here about, Denise, she says, what about the O-shot for urinary incontinence? Is that something that you're doing, Tracey? Now, I know that there are some GYNs who are doing that. It's not yet FDA approved, but it's basically just injecting something around the area of the clitoral hood, and it's being used increasingly to help women with orgasm. And one of the side effects of it for some people is that it helps with urinary incontinence. But I think as far as I know, they're still collecting some data on that, but there are some GYNs who are using that in different parts of the country.
Yeah, I think that it's not something that has, when you come across something as a side effect and it's beneficial, then, when you end up using it for urinary incontinence, it would be off label unless they extend their trials to include stress incontinence or to include incontinence. So right now, I don't have any experience with that in terms of treating incontinence.
Okay. Thank you, Dr. Wilson. We have another question. How effective is the injection? I think Michelle is talking about, this question popped up when you were talking about the Botox injection, and how long would it last?
Sure, great question. So we expect it to last 6 months. So Botox has many different indications. It's being utilized for crow's feet as we age. It's being utilized for migraine headaches. Again, it is great with causing muscle relaxation. So when your muscles are in spasm around your eyes, it's injected and it relaxes the facial muscles and therefore relaxes the crow's feet. Same thing with migraine headaches. It's relaxing those muscles that are in spasm. Same thing with the bladder. And regardless of what the indication is for the Botox, it is not a permanent treatment option. So for overactive bladder, we expect it to last 6 months. Anywhere from 6 months to 12 months. I've had patients where it has lasted 15, 18 months. I even just re-injected another patient just last month who her first and only injection was in February of 2019. So it's very variable. It is very effective. Some women, one patient has told me that she noticed an improvement as soon as she left my office and was on her way home. It was the one time she didn't leak trying to get in through the door. Most patients don't have the onset of efficacy that quickly, but you can expect it to have a noticeable difference within a week. And again, it'll last a good 6 months. There is a slight risk of urinary retention. So the recommended dosage for someone without a neurologic condition is 100 units. And there's about a 3% risk of having transient urinary retention after the injection. So again, if you're in a room with 100 women, only 3 might experience a problem, and it is usually short-lived. And it doesn't mean that those women cannot urinate at all. What happens is they tend to have difficulty urinating and may not be able to empty their bladders to completion and require a catheter to be inserted in and out maybe a couple of times a day. They're urinating on their own in between, but they're just having to get that residual urine left over out, and that usually passes after a couple of weeks. But very well tolerated and a very effective treatment.
Excellent, excellent. Now, as a follow-up to that question, would this type of injection be effective for a woman over 70?
Absolutely.
Okay.
Absolutely. And that's a great question. In fact, I would think that this is probably one of the mainstays for treatment for women over 70 because, as I mentioned previously, we have medications for urgent incontinence and they have potential side effects. And one of the side effects to the class of medications known as anticholinergics is that with long-term use, they're associated with dementia. So not the best treatment option, not the best class of drugs for our elderly population. And that's where the Botox is definitely more effective and safe.
Okay, excellent, excellent. So, so thank you for that. I want to shift back to kidney stones for a couple of minutes. We have a couple of questions about kidney stones, and I know I've had some patients in the past ask this question, especially if they have kidney stones return quite frequently. And so I wanted to ask a couple of questions we have from the audience and also based on other queries. What approaches do you take these days for kind of workup and management? And also, what would your thoughts be about someone who has a history of recurrent kidney stones, drinks a lot of water, still feels like she urinates several times a day. Do you have an approach that you would use for patients who have an ongoing issue with recurrent kidney stones?
So with my first response would be to the patient who, first of all, once you get a kidney stone, your risk of getting another kidney stone in the next 5 years is about 50%. If you're fortunate enough to pass the stone and retrieve it out of the toilet, or if you unfortunately landed in the emergency room and required surgery, the stone should be sent for stone analysis. The majority of stones are calcium oxalate stones, and that doesn't mean that you should watch your intake of calcium. But again, especially patients who are recurrent stone formers, knowing your stone composition is extremely, extremely important. Not only knowing your stone composition, but if you can plug in with a urologist who is interested in understanding how recurrent stone formers form stones, then that evaluation should also include not only a stone analysis, but a 24-hour urine collection, actually 2 24-hour urine collections, as well as blood work. Because we know that recurrent stone formers may have an issue with reabsorption of certain electrolytes. There are certain substances in our bodies that prohibit stone formation, and you may be deficient in those. There's certainly a genetic predisposition in some patients. Sometimes it can be associated with hyperparathyroidism. So there's a lot of things. It's basically called a metabolic stone workup. And, we're pretty advanced here in Alabama because my boss in particular is a world-renowned stone expert and runs a basic science lab on researching stones and patients who are recurrent stone formers. But the average general urologist has specialized labs available to them where they can send off your 24-hour urine collection, can send off your stone for analysis, and can give you some ideas of how to prevent stone formation. As I mentioned previously, the most common stones are calcium oxalate stones. And so that doesn't mean that you restrict your intake of calcium, but because there's so much fancy ways of which there's transport of different electrons and electrolytes across our kidneys, what you really should be watching is your sodium intake. So when you're taking in a lot of sodium, which doesn't necessarily mean just adding salt at the table, but a lot of processed foods, that's what you should watch. When you are a recurrent stone former, you should be drinking enough water so that your urine looks like water. For most people, that's about 2 liters a day. So the more dark yellow, the more deep yellow that your urine is, you're not hydrating yourself well enough. And so dehydration certainly leads to stone formation as well.
Awesome, awesome. Thank you so much for that, Dr. Wilson. Thank you. So I want to turn now to another surgery that you commonly do that that I think more and more people are starting to ask about and be curious about. It's a surgery that maybe even 20 years ago men didn't like to discuss at all. As an OBGYN, I'm a huge advocate for worry-free and joyful sex. And when it comes to sexual intercourse, what a lot of women worry about, especially if their sex partner is a male and they're in the reproductive age window, which is usually about age 11 to 51. So, for most women, there are a good 40 years when women are worried about whether or not they might get pregnant unexpectedly. And so most of pregnancy prevention methods or birth control methods, as you know, are for women. Many of them have hormones in them. There are some that don't. But more and more, I have patients who are asking for other options, either hormone-free options or let's say I have maybe a woman who's in her late 30s, maybe she has hypertension, she has other stuff going on. And rather than her taking the birth control, she wants to talk about or bring her partner and her male partner in to talk about his options. And right now, the main option that we have for men is a vasectomy. So I'm also glad you're here because I think sometimes people don't realize that vasectomies are done by your specialty, urologist. And so I wonder if you can give us a little update about vasectomies and in the 20 plus years that you've been practicing, if you're seeing an increase in them or not. What's the general kind of mindset of patients who are coming in to get it done? And then also if you can give us some feedback about the very common myth that vasectomies will cause a man to lose his ability to have an erection.
Good points. So first of all, ladies, if you only knew how quick this procedure is and how benign it is, none of us wouldn't be having this discussion.
Right.
It is truly, in a very skilled, quick, somebody who does these all the time, it is a 10-minute process. You know, most urologists do them on a Friday afternoon so that the patients can lay out on the couch with an ice pack on their scrotum for the weekend and be back to work on Monday. That's how easy it is. I think, you know, for me, I can only just speak about my own personal experience. I felt like I had done my part. You know, I carried 2 children to term.
Talk.
And I was like, you know, this is quick and easy, and I can be stress-free and not worry about, you know, taking medications long-term for 40 years that, you know, at that time, and still we are very concerned about how much exposure we have to hormones. You know, and especially speaking to those women who are in their 30s and they know that they're finished having children or don't want any children and want this stress-free sexual life. And I realize that things may change. You may get a different partner or something, and you may want to expand your family further. Reversing a vasectomy is associated with more success than reversing a tubal ligation.
Absolutely.
So it's not that it's perfect in that it's as if they've never had a vasectomy, but there are many men who have fathered children after having a vasectomy reversal. So it can be reversed. But I think that it's something that should be discussed. And again, it is just so quick and easy, and there's really not a lot of counseling that goes along with it. You know, many men show up in my office without their partner. And I'm sure I've done vasectomies on men whose partners had no idea that they were getting it. Because they could say that they're away for the weekend and come back and nothing's ever happened, that, you know, it's just as if nothing's ever happened. After having a vasectomy, we do ask for 3 semen analyses that show absolutely no sperm before we give you the green light to engage in unprotected sexual intercourse. There have been some patients who come back and say, look at my newborn, I thought I had a vasectomy. And then we look in the chart and say, well, you didn't come back and show us that you had 3 negative semen analyses before engaging. But unfortunately, after cutting the vas, those 2 ends can somehow find each other. So different surgeons have different techniques in terms of cauterizing the end of the vas deferens or folding it back on itself or placing a piece of tissue between the 2 ends so that they cannot rejoin. But that is a possibility. There's a lot of myths surrounding vasectomies. One has been, you know, 20 years ago, potentially associated with prostate cancer. And that is truly a myth. I think the issues with impotence or having difficulties getting an erection is more psychologic. There is no pathologic association between a vasectomy and getting an erection. We are nowhere near the neurologic system that would allow a man to have an erection. The structure that we're cutting for a vasectomy has nothing to do with the blood flow into a man's penis that allows him to have an erection.
Can you say that again, please?
We are not transecting. We are not messing around with the blood flow that allows for an erection. But what I think is the concern, I mean, Dr. Sutton knows as well as I do, it's amazing how many patients we treat who have gone through successful pregnancies, but really the stars need to be in alignment for the pregnancy to occur. And part of that is getting an erection that, number 1, is going to be strong enough to allow penetration, and number 2, last long enough.
Mm-hmm.
And it requires both psychologic, neurologic, and vasculogenic input for that to occur. So you could have a completely healthy man who has the great neurologic, the nerves intact to allow an erection, as well as the vasculature and the blood flow to allow an erection, but psychologically there's a block. So if he's undergone a vasectomy, and oh my goodness, what's going to happen when I ejaculate? What's going to come out? Is the volume going to be the same? Am I really sterile or am I not? What if I do get her pregnant? I mean, all of those things are playing against him. And the next thing you know, he's flaccid. So it's not that the vasectomy has caused problems with getting or maintaining an erection. Many times it's the psychological aspects that have sort of caused some difficulties.
Absolutely. Well, thank you. Thank you so much for that. I really wanted to help clear that up because I know certainly, like you describe, a lot of women are at the place of like, you know what, I did my part, and they're asking their male partners to do more when it comes to birth control. We have a couple of questions here about vasectomies. What is the percentage of the vasectomy failing or not lasting?
I don't think there's any such thing as a not lasting, because if you have gone through the 3 semen analyses and there's negative, there's no sperm, you're good. The issue is when there is, I mean, the vessels are the vas deferens, when I have a male come into my office asking for a vasectomy, my first thing is, again, go through his history. Has he fathered children before? Is he sure that he doesn't want any more children? I don't usually get into, are you in a committed relationship? Does your wife know that you're here? Many times the wife is there, many times she is not, or the partner. And then we do an exam. And if I can feel the vas deferens easily, then, you know, we're going to proceed. And so it can be done in the office. I would tell you that the men who are a little bit more stocky, a little bit on the more chubby side, and the men who are very muscular are the ones who are most difficult. And so there's a lot of pulling and tugging, and although we might give them a little Valium before we start, and we're certainly injecting the area with lidocaine, sometimes it can be challenging.